I'm going to start with introducing yourself because you've got such an amazing background. You've been running a private practice for the last 22 years, helping women and men of all ages with incontinence and pelvic floor dysfunction.
That's right.
And that encompasses so much. This means you're helping with stress incontinence, overactive bladder, urge incontinence, vaginal prolapse, pregnancy and childbirth, the menopause, constipation, bowel dysfunction, sex, and the pelvic floor. You're also the author of a book called The Pelvic Floor Bible, which you published 2 years ago, and I have read. And honestly, I can highly recommend it. It's so easy to read and so much information. And for someone who doesn't know where to start, I think it was a great start.
Thank you. I think that my book was deliberately designed for people, not medical profession, for giving information to women and men about pelvic floor dysfunction.
Regularly featured in the media, so people might have seen you in the Times, Radio 4's Women's Hour, Channel 5 News, and also you're the resident pelvic floor expert on Mumsnet. Such a great source of resource for many moms such as myself.
I think it's important to try and spread the word as much as possible about pelvic floor dysfunction, because it's still quite a taboo subject. As we know, menopause is starting to be highlighted a lot more, with the wonderful television program recently with Davina McCall, and Louise Newson's done a lot to raise awareness, and lots of people have. And I think that pelvic floor dysfunction is among those things that we struggle to talk about.
Since we're discussing pelvic floor dysfunction, can you explain what it means?
We are living longer. We are being much more active longer. So, my mother and my granny, they didn't run marathons and go to the gym. And, now we expect to be doing that into our 70s and 80s. And so we need our pelvic floor to help us through our lives more than it did before. I think women are, much more active, physically active than they used to be. Maybe they're doing less sort of physical housework, scrubbing floors and things, but they're certainly doing a lot more physical exercise. So our pelvic floor works as a hammock. It supports our internal organs. It's the bottom of our core. Without it, our innards would drop out. We really, need it. We need it to control our bladders. We need it to control our bowels. It helps our sexual function.
Just to clarify, it's a number of muscles, isn't it?
It is a number of muscles. And if you talk to the professors about it, they're still slightly, arguing about how many and how they work. But they're getting better, particularly with dynamic MRIs and ultrasound. But yeah, so if you think of it attached to your tailbone at the back and your pubic bone at the front, and you think of it as a hammock, sort of between the legs really, going back to front, and then to the two bones that we sit on side to side, so our sort of bottom of our hip bones, and you think of it as a sort of layer of muscles that contracts to stop us passing wind in an inappropriate place. And we've all had that crossing of our legs in an emergency when we suddenly think, oh my God, I'm going to sneeze, I need to cross my legs, quick, help. And so we contract our pelvic floor as best we can to prevent embarrassing accidents. And but we also need to use it to be able to open our bowels, to be able to pee. And so we need to be able to relax it as well as contract it. We need to understand how it works. And it's one of those grey areas where clearly when we're young, we're not taught about it. It's a difficult area to teach teenagers. And as we know, the menopause is now going to be discussed in schools, and maybe pelvic floor will come next, along with sort of menstrual health and things like that for young girls, particularly young girls. It's clearly a problem that happens much more to women than men. And that's largely due to childbirth and the menopause.
I understand your title is continence nurse specialist. I got that from your Instagram, bio, so I'm not making it that.
No, it's true.
So you're helping make the pelvic floor healthy, so helping with the muscle, making sure that it's working optimally. How does your work relate to physiotherapists? Because physiotherapists also work with muscle to make sure that they function properly. Is it the same type of work?
It is, yeah. It is, and in fact, I think there's a slight crossover. So, continence nurse specialists. I trained as a nurse. I then actually was a district nurse, so I was a bit like Call the Midwife. I went around in a blue mini. And then at the very beginning of nurse specialisms in the late 90s, I got a job in the NHS as a continence nurse specialist. And I've kind of more specialised in pelvic floor dysfunction, which, yes, is helping train muscles, looking after prolapse, helping people with stress incontinence and the overactive bladder. But I also do things like care for people with urinary catheters and things like that. So in this sense, that's not what we're going to talk about, but I do both because I'm a nurse specialist. But yes, there's a very big overlap between pelvic floor physiotherapy and what I do.
What to expect, if we went to a continence nurse specialist such as yourself, would we have to do exercise, or what to expect?
So I think the first thing is to make sure we find out what actually is the problem, because in menopausal women, in general, the problems are stress incontinence. It happens when we cough, when we sneeze, when we laugh, when we jump, particularly trampolining. I think for the menopausal woman is a bit of a no-no. So if you laugh and you suddenly wet yourself a little bit, that's stress incontinence. It doesn't mean you're stressed. It means that when there's an extra stress on the pelvic floor, you can't hold in a tiny bit of urine. And so with that, it's pelvic floor rehabilitation in general, which I do with various things. So I'm a kind of gadget girl. So clearly the first thing is pelvic floor exercises. Sometimes, if you've had a few children and maybe you've got a lack of estrogen in the vagina, making pelvic floor contractions is actually quite hard. And so you can read about it and it says, contract your vaginal muscles, hold on for 10 seconds. But quite often when I examine women, there's no way they can hold on for 10 seconds. So I use biofeedback. So we use an electrode in the vagina, and we look at on a screen to see how long and how strong somebody can hold a contraction for. I will do things like use electrical stimulation of the pelvic floor. I use the LV trainer a bit. That's quite helpful because it gives feedback and it's encouraging. I use vaginal weights a little bit. It really is personalized to you. Because if things like vaginal weights won't work if you have a prolapse, but if you have weak pelvic floor, a bit of stress incontinence, you've got 2 young kids and a full-time job and looking after granny, you haven't got a lot of time left to do zillions of pelvic floor exercises. So if you can use something quickly for 5 minutes in the shower or whatever, I just try to tailor it personally to each person, because I think that's what's important.
And do we need to be referred to go to a specialist like yourself, or can we just book a session? Or
yeah, you can just book a session, and I think most pelvic floor physios, you can do that. If you want to use health insurance, then you have to go through your doctor. But for just a one-off, finding out how your pelvic floor is, and we all should know how our pelvic floor is.
And when do you recommend we assess, how our pelvic floor is? Is it after pregnancy? After delivery, in our 40s? When do you think is optimal? Because I like to share that in France, after pregnancy,
yeah, I know,
they have like special sessions. I can't remember how many, just to make sure it's working again.
Yeah. 10.
Here it's like, we are given a piece of paper with exercise, but personally I'm not sure if what I did was right or not. So I'd be very curious.
Exactly. How do you know you're doing it properly?
Exactly.
That's the problem. And I think there are quite a few sort of groups of setting up things like mummy MOTs after pregnancy to do that, because there's a demand amongst women for it. I think as we learn more about our bodies, we're thinking, well, why are we not getting pelvic floor rehabilitation? I think probably we should be getting it as young adults. I think you're in a difficult area with teenagers or the young. So I think with young adults, maybe there's in the future something could be like in a gym. You could just go and test yourself somehow and see how your muscles are working. But clearly it's more, the start would be having had a baby. And then maybe again at the menopause, because at the menopause things change. You have as your estrogen levels drop, The estrogen keeps our vagina moist. It helps us to prevent us getting urinary tract infections. So suddenly you might find you're getting more infections. Due to a lack of estrogen around the urethra, it has a lot of estrogen receptors, which are needed for us to stay healthy. And we also get vaginal dryness. And so at the menopause is a very good time to just go and have a look. I see too many women, I mean, examining women every single day and I say to them when I examine them, when was the last time you had sexual intercourse? And they'll say, oh, it's just too painful. I can't do it. It hurts. I get a urine infection. I'm in pain for a week. And so many people have given up their sexual life just because of a lack of vaginal moisture or estrogen. And there's lots of nice vaginal moisturizers out there. I'm a fan of Yes Vaginal Moisturizing.
We're going to have a chat. We're going to have a chat in a few weeks, so I'm super excited to introduce them.
Excellent, because I think that's a great product, and the patients that I've given it to. So some women will use vaginal estrogen, and you can do that in the form of either a pessary, Vagifem is one. You insert it.
But you need a prescription for.
Yes, you do.
Yes, you do. Yes. That's you can just buy it. So
that's correct. So if you're, you really are in need of estrogen and you're getting lots of urine infections, you can have vaginal estrogen. If you don't want to, or that's not right for you, then yes, vaginal moisturizer. Silk do another one, but at least you can give back the moisture to the vagina, which if you didn't know that was the reason that suddenly intercourse was awful, and with the menopause, there are lots of other symptoms which maybe are putting you off sex, but then when you actually do it, it's blooming painful. It's not going to make you want to do it again, and it shouldn't be because of a lack of vaginal moisture. What you don't want to do is wait until things have become worse. So the other the other three common things, as you said at the beginning, are constipation. And if you have already a bit of prolapse, we know that 50% of women over 50 have a degree of prolapse. It's huge. A lot of women have a grade 1 prolapse and they don't even really know that they have it.
Perhaps you can explain what prolapse is.
Prolapse, its proper name is pelvic organ prolapse. So if you think of your vagina as a tube, your uterus is on the top and the vagina like this. You've got your bladder at the front, your vagina in the middle, and your bowels at the back, and your uterus on top. So pelvic organ prolapse can be one of three things. It can be that the front wall of the vagina collapses a little bit. Imagine this as a vaginal hernia, and the bladder then sort of bulges into the vagina. The same can happen at the back. The rectum bulges as the bowel is full, it bulges into the vagina. That's a rectocele. I didn't say that the front wall one is a cystocele. So the bladder bulging or the bowel bulging. Or you get a uterine prolapse, so it collapses down from on top. If it's serious, women describe it as feeling like they're sitting on an egg. If they're looking in a mirror, sometimes you can see something sort of bulging out at the entrance to the vagina. These are sort of quite, grade 3 or 4 prolapses. But if you have a tiny prolapse, so grade 1, so you've got a little bit, and it's usually caused by stretching of the vaginal walls during childbirth. Then as your estrogen levels drop at the menopause, and then you get a bit of constipation, a tiny little weakness in the pelvic floor can be then exacerbated by the constipation, causing what was a grade 1 prolapse to be a 2 or 3. So if you have an examination sooner rather than later, you can have it highlighted that, oh, well, in a way it's like an accident waiting to happen. And I'm not saying it's going to happen, but it's better to make sure it doesn't. The bladder one as well, if you have a bulge at the front wall of the vagina, a cystocele, it leads to more urine infections. And particularly with intercourse, again, as you have intercourse, it pushes your bladder back and can cause irritation and cystitis. And I think that it's a very treatable problem when it's small. When people come to me with a serious prolapse, it's very difficult to actually cure it with pelvic floor rehabilitation. But I'm always, anybody who's listening who has a prolapse, who has been suggested surgery as the first resort, always the last resort. Always, always. In between surgery, you can do pelvic floor rehabilitation to start with, which everyone should do anyway, because if you end up with surgery, at least you are sure that your muscles are as good as they can be. But following the pelvic floor rehabilitation, in the middle of that is pessaries, vaginal pessaries, which are wonderful things, and they are very empowering. If you've stopped running, you've stopped playing tennis, you've stopped doing the things that you love to do, think of a vaginal pessary as a sports bra. You wouldn't go running without your sports bra on, would you? Boobs would joggle about, they'd be awful.
No.
So a vaginal pessary, they come in various shapes and sizes. They can be cubes, they can be round, but now they used to be horrors, a bit like an old deck hoit. They were horrible, hard, white, round things. But now they are made of silicone. They're a bit like the old Dutch caps, so they're a bit like an old contraceptive, and they sit in the vagina and support the prolapse, so you can get on with your life while you're doing pelvic floor rehabilitation. And I think that everybody who has one that I've treated, it's like, my God, I feel normal again. Before we ever rush off to surgery, because the surgery, and particularly at the moment, any surgery for prolapse,
is it the mesh?
So the mesh.
I was wondering.
I was about to say.
It doesn't always work, and it can have some serious side effects, from what I read.
Well, it can, and at the moment it's largely sort of banned. So, pelvic, prolapse surgery, won't be done with mesh. It is a little bit, but not so much, because they're having all sorts of trouble. But so always go for the other options first. In that
natural
case.
ones,
right?
All for the natural first. And
that definitely. Yes. Surgery's last. The thing is, you've always got that option if it is, and clearly some people need either a hysterectomy or they need surgery. If things have gone beyond the point. The point is, if you can try to care for your pelvic floor health earlier, hopefully you will never reach that point. The last thing that we haven't talked about, which is quite prevalent in menopausal women, is the overactive bladder. And so if you're suddenly
what does it mean?
So if you're suddenly finding that, every time you have a naughty macchiato, you're desperate for a pee, and you really think, my God, I know where every loo in London is. Oh my God, I'm going from my house, I'm going to this shop because I know there's a loo there. And so if you, it's basically urgency and frequency to the loo. So if you suddenly think, God, I'm going to the loo a lot. Oh God, I'm desperate, absolutely desperate, hopping up and down on your front doorstep with the key, and then it can be turned into urgent incontinence, which is literally, having incontinence on the doorstep as you're trying to get the key in the door. And it's very distressing because, we've always been in charge of our bladders, and suddenly to find that you're not, and that actually, you've peed yourself trying to get in through your front door. It's very upsetting, and it's very curable. Nobody should live with the overactive bladder. There's lots of things you can do. Certainly pelvic floor rehabilitation to start with. With the overactive bladder, there's definitely an element of mind over matter.
Okay.
Because once you get into that point, I saw a lady last week who said to me, I am so worried about lockdown ending. I've so loved it. I've loved it. And I said, why? And she said, well, because I'm not worried about where the nearest loo is. I'm at home. And I think that's a terrible thing to say, or to admit to, that, she'd got herself into that state, and she mustn't, nobody has to live like that. And I think, clearly fluid intake in the form of fizzy drinks, coffee, we all know this sort of tea and alcohol can make it worse. And I had one patient who was literally cured of the overactive bladder by stopping drinking fizzy water, because she thought it was really good for her, but it just didn't agree with her. And so we just have to kind of look at our lives and what's happening to them. And with the overactive bladder, there is medication you can take if required. I do a treatment called tibial nerve stimulation, which is slightly unusual. Put a needle in your ankle acupuncture. It's like a form of acupuncture.
Okay.
It's not painful. I've never had anyone leap off the table and run away. And it stimulates the tibial nerve and it calms the overactive bladder. So there are lots of things we can do to help it. And one thing we mustn't do is suffer in silence and think, oh God, you know, this is my lot. Because quite often either people don't seek help or they've been told by their GP, well, what do you expect? You've had 2 kids, you've got the menopause, you know, and it's just not true or fair. And that's so why I wrote the book, to try to pass information to women. You know, it's just, there just isn't enough information out there about pelvic floor health.
Let's discuss your book. I loved your book, honestly.
Thank you very much.
Thank you so much for writing it. I think, you know, I'm going to recommend it to anyone. How did the book happen?
I had a patient who came to see me probably about 4 years ago, and she said, you've got to write a book. She's an author, and she'd written a few books, and she said, you've got to write a book. And I said, don't be silly, I'm not an author. And so off she went, and then she came back a few months later, and she said, well, have you written it? I said, no. And so, you know, it's a journey. So she introduced me to a literary agent, and then Penguin said they wanted to publish it. And that's how it started. And I just really, it's from the work I do. I know what people are struggling with, and I tried to write it for women all through life. I mean, clearly I put a bit about postnatal ladies, and I did a chapter for men. I didn't expect many men to buy the book, but I thought lots of women, hopefully of our age group, would give it to their husbands to read. It's actually just about to come out in Spanish, which is really exciting news.
Wow.
It's just based on what I do really every single day, and I have loved doing for 25 years. It is my passion, my joy. I know now that running and sort of high impact things can affect the pelvic floor over our lives. But we're all now, you know, not it's good for your joints and other things.
Exactly, it's good for
to
the
be caring for your
bones.
pelvic floor. And to care for your pelvic floor. And so you have to kind of balance all of those things and say, yes, I'm, you know, you look at me, I'm having to wear glasses now to see you because I, you know, from the age of 48, I need them for reading. And so we have to be sensible about how and where we are with it. But we certainly do not ever need to accept stress incontinence, the overactive bladder, prolapse, or constipation as normal. But what we need to be is at a point where we are not bothered by our symptoms anymore and get to a point where we can manage them. Now, if in prolapse, that means wearing a pessary, that's fine. If in constipation, it means that you, I'm a fan of artisan fruit cubes and the raised footstool. So feet on a stool, some figs or the artisan fruit cube, which I love because they, you know, it's very natural. If that's what's needed, far better than you suddenly end up with a bigger prolapse. But it's managing your symptoms and expectations of how you will be. And largely, if I feel I've kind of cracked it, if somebody says, I'm actually not bothered by this anymore, and you know, they can sort of go off into the sunset and live their lives happily. You know, clearly your pelvic floor is always going to love, you always need to love it forever and ever. You can't just go, oh, well, now, good, I'm not bothered by it anymore. I can just, you know, abandon it to its fate now. And
I remember there is an app that you mentioned in the book. Do you recommend that we read the book, we try the app, and then if we can't get it, we contact someone like you? Or?
I think so. So the app is called Squeezy. It's a really good NHS app designed by some physiotherapists who are great, and they've won some awards for it. It's a super app, and you can set it to, you know, squeeze for 5 seconds, 4 seconds, 3 seconds. It's quite intuitive, and it sort of counts down for you to can't cheat and count to 5 really fast. And I think that's a good thing. The perfect ideal world, wouldn't it be amazing if sort of all of us had a proper health check even at 25 and you know, everything was looked at. You know, we had a look at our eyesight, and you know, we had a proper medical health checkup. You know, that would be my utopia, that we did that for everyone. But maybe it's going to be a while down the road. And at least if you understand your body, you understand that these things aren't normal, and they are often curable and certainly better managed, always better managed then I think that is a place to start.
What do you wish you had known 3 years ago?
Thinking about my book, I wish I'd known how to use a computer better, because my computer skills have gone up hugely. It was a steep learning curve. And so I wish I'd had better computer skills, and they were not good, and they are much improved as a result. And actually it's helped me to do all sorts of other things. I'm doing a webinar in a few weeks' time, and so that has helped me hugely.
Now, would you have any tip for women who are going through the menopause?
I would say care for yourselves, everyone, because, you know, we are, as I just said, we are that sandwich generation where we're caring for the young, we're caring for the old, we're doing full-time jobs, which largely our mothers and our grandmothers, maybe our grandmothers didn't do. You know, we are juggling so many balls, and we just need to care for ourselves more, because I think it will help us in the future, and we will live longer. We're going to live a third of our lives in the menopause. So, you know, it's sort of 100 years ago, we sort of would be dead at 70. Now we're going to live to 100. And
which is so exciting.
Which is fantastic. But we need to, you need to care for yourself.
Yes.
More, I think.
With regards to supporting women going through the menopause, who do you think I should interview next? Anyone you would recommend?
Somebody who understands about vaginal dryness.
Okay.
As far as I'm concerned, I mean, that's my huge thing in the menopause for women.
Does it have a title? Well, the specialist that would look after women who have vaginal dryness, because
so
I didn't know that.
Yeah, well, possibly a dermatologist. Or possibly a menopause specialist. So a menopause GP who specializes, you know, a particular interest in vaginal dryness, which, you know, used to be vaginal atrophy. It sounds like we're sort of, you know, shriveling up and going, it's horrible. So it's such an easy thing to deal with. But as I say, I see too many people who I'm having to show how to use vaginal dilators, you know, because everything, particularly women who've had cesarean sections, interestingly enough.
Really?
Yes, because as the vagina dries and it becomes very small, and so beware, because that can, you know, if you don't look after the tissue of the vagina, can. So I really do think that would benefit huge amounts of women to have a chat about that. I think I heard Liz Earle, because I was doing the questions for it. She talked about it, and that's great, because somebody like her who is, you know, women are listening to her and watching her, you know, for her to talk about that and say, you know, I think that was very important. And so if we have women who have influence who say they use vaginal estrogen, I have to say I do. And I think that, you know, there's no shyness in saying that. I think it's helpful. I use Vagifem, and I think you can either use that or you can use the moisture, you know, the SVM, which I recommend too.
Jane, thank you so much for your time tonight. It was such a pleasure to have this wonderful conversation with you.
My pleasure.